Thank you, Chairperson, sir. Distinguished colleagues, ladies and gentlemen. So the departments of surgical gastroenterology and radiotherapy started more or less simultaneously in this institute in 1990. The surgical gastroenterology had started before services, slightly before that. And it's been close to 3 decades now. It's been over 3 decades that we have been working together. Cancer of the esophagus is one such disease where a variety of reasons, it emerges. One of them has to do with the dietary habits of people, particularly the use of betel and areca nut, and then there is also alcohol, and then there's reflux there, which is particularly associated with the adenocarcinomas. So let us just go through. So the plan of discussion today will be that we'll talk about the cancer burden of esophagus in India, and then zero down on SGPGI. What has been the evolution of cancer treatments of cancer esophagus over the past 3 decades? The process of care and how a dedicated clinic, which essentially is another word for people, for doctors meeting up together and discussing patients more intensely than we normally do. That is what it all boils down to. Talking about the demography and sharing the data, which is then divided arbitrarily into a dissection of the non-surgical, or in this case, the pre-surgical data interventions by the radiotherapy department, the surgical management by the Department of Surgical Gastroenterology, the data seen in context with the best standards available currently, and then some reflections, summary, and acknowledgements. So the cancer scenario in the country is mapped by the National Cancer Registry Program, led by a certain Dr. Prashant Mathur on behalf of the ICMR, and this is located in Bangalore. They map cancer incidence in what are known as population-based cancer registries, which means that it effectively captures data from different regions of all comers, and they eliminate duplicates. So that is the great strength. And they inform us that in the year 2020, the projected cancer incidence of the country was about 14 lakhs, with 52,000 esophageal cancer patients projected across the country, because the population-based cancer registry does not map every single corner of this country. So that amounts to about close to 4% that you can see. So in SGPGI, over the last 15 years, 2005 to 2019, we have registered about 27,000 patients. 1,400 of these were cancer esophagus, which makes it 5% of the total amount that we see. Of these, those that were intended for surgery were less than 15%. And of those that were intended for surgery, less than half eventually got operated. So that's just 6% of the that's about 6% of esophageal load in SGPGI. What is more to the point is that esophagus, although small in numbers, it is the most prominent cancer in the Northeast. If you look at these states, the seven sisters, the eight, on rather eight of them there, Mizoram, Sikkim, Tripura, Meghalaya, and Nagaland, and then you have Kachar district and uh, Kamrup. Now, esophagus is either the first or the second most commonest or the third most commonest from the top. And then you have a smatter of other areas. This is Barshi and Wardha is West Bengal, is Maharashtra. And then, of course, Patiala, there is probably substance abuse there as well. And this is predominantly in males and not so much in women who have other issues, breast and cervical cancer. But when present, it is again in the same area. And I've had an opportunity to visit this place that when you go to these states, they, as a matter of respect, they offer you the betel leaf and the areca nut. And that's peculiarly done in such a way it's soaked for about several days underground. It's buried and taken out, and it acquires a different flavor, but also possibly more carcinogenic properties. So how has the evolution of cancer esophagus been? It stands to reason, though now it has been challenged, that if something can be removed, the surgeon will remove it, and with good reason in the past, as that was the only effective and definitive treatment. So initially, for the first 15 years, between 1990 to 2005, anything that the surgeons deemed operable was operated upon, whether they were squams or adenocarcinomas, and they were followed with adjuvant radiotherapy, because you can imagine the anatomy of the esophagus, that it is lying in close proximity and intimately with mediastinal structures where dissections are challenging. And there is, because of the lymphatic spread, there is nodal involvement, and it may or may not be possible for a variety of reasons to access those areas. And so there will be residual disease. So when there is residual disease, there is an indication to contain it by giving radiation. And of those patients who were referred for radiotherapy, a third of them did not receive it. They did not comply. And those who were complied, it's interesting to see that only half of them complied by 6 weeks. Now, 6 weeks is not a magical figure. The problem is that if you provoke the tumor, it starts growing, and it grows exponentially. So the longer you wait after provoking a tumor, the longer you have a greater number of clonogens and reduce the tumor control probability. So what's happening is 50% by 6 weeks, but treatments are going on starting as late as 3 months. It's probably worthless, they say, to give radiotherapy after. So patients are not complying. This was the primary reason for changing and rethinking this issue, and it has been recognized worldwide. The median survivals were impressive in context with the radiotherapy alone patients, and I'll just talk about it. And the 5-year survivals were 17% for this select group, which constitutes about 5% of the total esophagus load. What about the 95%? In the 95%, at that point in time, we used to give radiotherapy alone, and we tried different combinations. The median survival was 8 months, and the 5-year survival, 5%. You can compare the two. They're different populations. And subsequently, we increased the intensity of treatments by giving both chemotherapy and radiotherapy, and the survivals increased marginally. And we could see this in a phase 2 trial, that it was about 17%. It was a mixed bag. And then it took to reason to see whether it is really making a difference by a randomized trial. And the survivals changed were initially, again, so you can see the survivals are hovering around 7 months, 8 months, 9 months. There's a confidence interval there. So this jumped from median from 7 to 13, but nowhere near the 17% median survival of surgery, even at that point in time. The 5-year survivals were increasing from 13% to about 25%. Okay. Now, subsequently, between 2005 and 2015, we switched from post-operative radiotherapy to pre-operative radiotherapy, and then pre-operative chemoradiotherapy. And that is the subject of the presentation today. For those that were inoperable, they went on to receive various combinations of chemoradiotherapy, and we continue to, that represents the standard of care. Why did we go to preoperative strategies. Now, radiotherapy, when preceding surgery, radiotherapy following surgery was not working for a variety of reasons. We discussed that. So when it was preceding, we had good evidence by that time that at least in some, there was a survival advantage. In some of the trials, there was a survival advantage or a reduction in the local failure rate when radiotherapy preceded surgery. But the data was not convincing. It was difficult to recommend outside a clinical trial. But nonetheless, it was tantalizing because the surgeons, in order to operate a patient, must get a feel of it. So the first things that we did in our strategy was to just give radiotherapy. There's another thing to the point. The radiotherapy was given, and within 8 days, the following week, the patients were operated. There was some theory at that time that the edema caused facilitated dissection, and so this was done. This is not followed now. But this was, at that time, the fashion. And it was evidence-based at that point in time. And the doses were also typically very less. 20 gray is not a tumoricidal dose to any degree of effectiveness in the context of squamous carcinomas. Another thing happened. Because this was not working, so they said, why not add some chemotherapy to radiation? And that, at that point, the data was emerging, and in fact had emerged, that chemotherapy improves survival. And you can look at the odds ratio, 0.66. The probability of resection was dramatically better. Operative mortality also was concerning, and we will see that data now. And an all-cause mortality was also increasing. It had to do with learning curves and ability of people, the team, and local regional recurrences did come down, but all in all, the survivals increased. So let us now look at our data, and I would invite my colleague, Dr. Kivan. Please come down, Dr. Kivan, and he is going to share the radiotherapy data, and after that, Dr. Kush Parikh will take over from the surgical perspective. These divisions are, of course, arbitrary.
Thank you, sir. From the period of January 2005 till December 2019, we have 207 patients who were deemed eligible or resectable and were given neoadjuvant chemoradiotherapy by the multidisciplinary tumor board in the clinics. Out of these 207 patients, 11 patients only consulted and never returned back for the treatment. And around 190 patients were able to complete the neoadjuvant treatment. But out of these 190 who were able to complete the neoadjuvant treatment, only 101 were referred for surgery. There were different reasons for the patient opting out of surgery, such as refusal in 17 patients, progression of disease after neoadjuvant seen in 16 patients. Finances was a major issue for our set of patients, medically inoperable, and there were 8 reported deaths after the neoadjuvant treatment. The ones who made it to the surgery, 88 were resected, 2 palliative surgeries, and 11 abandoned surgeries. If you look at the demographic profile of the entire cohort, our patients were median age 57 with a range of 20 to 75. We are male predominant population in esophagus. Our KPS lies between 80, which is ECOG 2, and the significant percentage weight loss, that is more than 10%, was seen in more than half of our population. The median length was 6 centimeters, ranging between 2 to 15 centimeters, and about 96% of our patients were clinically node positive. A brief about the treatment protocol. When a patient came to the clinics, the MDT discussions undergoes between a gastrosurgeon and radiation oncologist, and patient is categorized either resectable or unresectable. When a patient is deemed unresectable upfront, so they are given radical CTRT, which is the standard of care, and the patient who are deemed resectable undergoes neoadjuvant treatment, which is neoadjuvant chemoradiotherapy. These patients receive a neoadjuvant radiotherapy dose of 45 gray in 25 fractions, 5 days a week, Monday to Friday, and then over a span of 5 weeks. And these patients also received concurrent chemotherapy, which was weekly CTDP, which is cisplatin. After completion of the radiotherapy and chemotherapy concurrently, these patients are reassessed after 4 weeks. with imaging and with gastrosurgery for assessment of resection. And these patients who were operated, they were between a span of 6 to 8 weeks after completion of neoadjuvant chemoradiotherapy. Now, let me take you through a brief about the radiotherapy planning process. When patient first comes to the radiotherapy department and for radiotherapy, we take a planning CT scan in our department, and it's not a one-day treatment. Patient has to come 5 days a week for the next 5 days, 5 weeks. So for the CT scan, the patient needs to be comfortable. The position is the most important thing, because if there is a positional error, the treatment error occurs. So we make sure the patient lies comfortable, supine, with hands above the head. And we have certain gadgets which we use to make him comfortable. We can see this is the head and neck rest, and this is the T-bar, which is used for the patient to be comfortable when he keeps his hands above the head. So this is our planning CT. This section shows the gross tumor volume, which is the macroscopic tumor, which we see on radiologically. And to this gross tumor volume, we give clinical target volume, which is the microscopic disease involvement, and the planning target volume, which encompasses for the positional or setup errors. 3D conformal radiotherapy. This is our conventional technique of radiotherapy, and around 98% of the patient in this cohort who received radiotherapy were treated with this technique. In this, we have AP and PA fields plus a lateral field, and it was a conventional field. We used it for the span of, this was being used earlier on. And as we can see in this technique, there is more dose to the adjacent structures, such as, which is an organ at risk like heart and lungs. This is a 95% dose color wash, which we can see the heart receiving dose and going to the lungs also. Now we have been using IMRT, which is intensity modulated radiotherapy. It is an advanced technique, and we have graduated ourselves from 3D CRT to IMRT, and we have reduced the dose to the neighboring structures or the organ at risk, and the dose of radiation is now confined to the tumor volumes only. Talking about the treatment profile of these patients, as we said, 11 patients never returned back for the treatment. They were excluded from the treatment profile. About 190 patients completed the treatment, and there were NACT, this is the neoadjuvant chemotherapy, was received by 113 patients. Most common neoadjuvant chemotherapy was cisplatin plus Xeloda. Xeloda is capecitabine. And the median cycles were about 1 cycle before chemoradiotherapy. Concurrently, we give cisplatin. Most commonly, cisplatin was given in about 2/3 of the patients, and RT dose 45. It is important to mention that 32 patients out of these patients were dose escalated due to various reasons, as they were deemed inoperable or unresectable. So the radical dose of RT was given to these patients. Talking about the toxicity during NACRT, as this is a retrospective cohort, we have some incomplete recorded missing values. So we don't want to undermine the toxicity, but neutropenia was seen, at least grade 1 was seen in 13% of patients, and odynophagia was present in 15% of the patients. And we have 8 reported deaths, 4 out of toxicity, and 4 were deemed due to progression. Coming to the clinical radiological response to neoadjuvant treatment, at least 2/3 of the patient had 1 grade of dysphagia relief. And radiologically, if we talk about the response, around 50% of the patient had partial response. Demographic comparison. Now we have 2 sets of patients, one who underwent surgery and the one who was not able to underwent surgery. So we did a comparison between these 2 kinds of cohorts, and we saw that the patients who was around 58 years of age were not operated, and the ones who were a bit lower, like 54, were operated, and this significant there was significant difference, and the p-value was 0.008. Location of the tumor matters for the for operability. Most of the tumors which were located in the middle thoracic were not operated, around 64% of the tumor, whereas the lower thirds get operated. Now I would like my gastrosurgery colleague, Dr. Push, to share the operative details.
Thank you, Dr. Kivan. So I'll be providing a brief overview regarding the different surgical approaches for esophagectomy, the slight details about the lymphadenectomy and the concept behind it, the experience of surgical gastroenterology department from 2005 to 2019, and the dawn of robotic surgery in the field of esophagectomy. So coming to the different surgical approaches, primarily we have got two different surgical approaches. One is open surgery and one is minimally invasive surgery. In open surgery, we can either do it transhoracically or it is done transhiatally via the abdomen. In transthoracic, we've got two approaches. One is the two-phase Ivor-Lewis approach, where we open the abdomen, we finish the abdominal phase of the dissection, make the conduit, and complete the thoracic dissection transthoracically, and the anastomosis is located intrathoracically. And the second is McNeon's approach. It is a three-phase esophagectomy, which I'll be mentioning later on. And the second approach is transhiatal esophagectomy, which is a completely transabdominal approach, and the anastomosis is done via left-sided cervical neck incision. In minimally invasive esophagectomy, we've got two approaches. It can either be done using thoracoscopy, that is video-assisted thoracoscopy VATS, and it can be thoracoscopic assisted, where the thoracic phase is done minimally invasively and the abdomen is opened and the abdominal phase is completed via laparotomy. And it can either be done laparoscopically also, so which is a thoracolaparoscopic approach. That is complete minimally invasive approach. And the second is robotic approach, which is RAMI. So on the right side image, you can see this is the Ivor-Lewis two-phase esophagectomy. First, we complete the abdominal phase via midline laparotomy. We complete the lymphadenectomy, make the gastric conduit, and then the abdomen is closed. After that, the patient is put in a left lateral position and a right-sided thoracotomy is made in the fifth intercostal space. And the transthoracic dissection is completed. The mediastinal lymphadenectomy is completed. And the anastomosis lies in the thorax at the level of the carina, which you can see in the image C. On the left side, we see the transhiatal esophagectomy, that is the Oringer's technique. A midline laparotomy is done. Similarly, the abdominal phase of dissection is completed. And then we open the neck via left-sided incision. We complete the neck dissection, and the mediastinal dissection is done bluntly, and it is a blind dissection. However, it is quite safe and quite accurate, and it's a published technique. But here, the anastomosis lies in the neck. Now, the difference between Ivor-Lewis and McNeon's approach is that in McNeon's approach, we add three incisions. The midline laparotomy and the transthoracic incision in the right fifth intercostal space is made similar to the Ivor-Lewis technique. However, the anastomosis is made in the neck on the left side. So why there are two different locations for anastomosis? There are two schools of thought. The intrathoracic anastomosis, the leak rates, the anastomotic leak rates are less in the intrathoracic anastomosis. However, the morbidity is quite high because if there is a leak, there'll be mediastinitis and the post-operative morbidity is quite high. Vis-a-vis in the left-sided neck incision, when the anastomosis is constructed in the neck, the morbidity is low. Even the leaks can be managed by the local wound care. That is why it is preferred by many surgeons. Not to ignore the length of the tumor and the margins when it is being considered. So coming to the minimally invasive surgery group, the robotic surgery and the thoracoscopic surgery initially from 2005 to 2012 were primarily being performed in the left lateral position, that is the semi-prone position. From 2012 onwards, we started switching to the prone position, and after 2015, all the procedures have been done in the prone position. As you can see on the image in the right, the patient is lying prone, the right arm is extended and abducted. The advantages of the prone position are it improves the exposure of the operative field on the right side because the wing of the scapula goes right, goes to the right and anteriorly. Second is it is better ergonomically for the surgeon to operate. And third, regarding the ventilatory parameters intraoperatively. We do not require a single lung ventilation for this. A double lumen tube is not required, and intraoperatively, both the lungs are ventilated and the pulmonary morbidity postoperatively is also less. So coming to lymphadenectomy, for esophagus, we've got three basic lymph nodal fields. One is the abdominal field, that is from station number 1 to station number 9. Second is the thoracic field, which is from station number 105 to station number 112, which constitutes the mediastinal lymph nodes. And the cervical field, that is the neck, which constitutes station number 101 to 106. That is the superficial and the deep cervical lymph nodes and the paralaryngeal and the prelaryngeal lymph nodes. So after 1994, before 1994, we did not have a consensus regarding the standardized nomenclature for lymphadenectomy. After 1994, the International Society for Diseases of Esophagus came with a standardized nomenclature, two-field lymphadenectomy, which includes lymphadenectomy of the abdominal field and the mediastinal field, in which we've got three variants. One is standard, where we perform the abdominal lymphadenectomy and the mediastinal lymphadenectomy up to the carina. Extended two-field, where we extend the mediastinal lymphadenectomy to the right side of the trachea and along the right-sided recurrent laryngeal nerve. And the total two-field lymphadenectomy, where the lymphadenectomy is extended to the left side as well. Three-field lymphadenectomy includes the cervical area, the neck lymphadenectomy. It is not widely followed in India. It is predominantly done in Japan. They've shown overall survival benefits of three-field lymphadenectomy, however, at a cost of increased post-operative morbidity. So coming to the experience of the surgical gastroenterology department from 2005 to 2019. So from the radiotherapy department, we effectively received 101 patients who were deemed eligible to undergo surgery. Out of that, 11 patients were unresectable. 8 of them were unresectable due to locally advanced disease infiltrating either into the airway, into the aorta, or into the lung parenchyma. One patient had obvious metastasis, which was away from the primary site of the tumor. One patient could not tolerate anesthesia intraoperatively, and that is why it was abandoned. And in one patient who was a chronic alcoholic and had cirrhosis, there were dense collaterals in the operative field, which led to the surgeon abandoning the surgery. So effectively, we had 90 patients who underwent total esophagectomy. 2 of them underwent esophagectomy due to palliative intent because both of them had tumor bleeds. So it was done to control the bleeding from the local tumor. And 88 underwent intended curative resections. All of them had received neoadjuvant chemoradiotherapy. So the tumor characteristics of these 88 patients, the main chunk of the tumor is in the lower 1/3 of the esophagus. That constitutes 63.6%. Second, to top the list is middle esophageal tumors, which is 28.4%, and upper and G-junction tumors form the minority, where upper is just 2%. That too in the initial phase of esophagectomy in 2005 and 2006. After that, all cervical esophageal tumors have been treated with definitive chemoradiation. Coming to the histology, mainly, we are dealing with squamous cell carcinoma, that is 96.5% of patients. Adenocarcinoma forms a minority, 3.5%. So surgical approaches, open surgery, we have 33 cases out of 88. And minimally invasive group, we've got 55 cases out of 88. Open surgery, again, most of the cases, around 25 cases were performed up to 2015 to 2016. After that, most of the cases have been performed minimally invasively due to benefits of post-operative morbidity and decreased pulmonary morbidity in the minimally invasive group. In the open group, out of 33 patients, 26 underwent transhiatal dissection with neck anastomosis, and 7 patients underwent transthoracic esophagectomy, again with a neck anastomosis. That is the McNeon's esophagectomy. And only 1 patient required conversion from transhiatal to transthoracic because of bleeding from the bronchial artery. In the minimally invasive group, we have 43 patients who underwent thoracoscopic assisted. Eventually, 2014 onwards, we've performed 11 cases who underwent completely minimally invasive surgery with 0 conversions. So essentially, these figures show that most of the conversions were due to difficulty in the transthoracic dissection, not during the abdominal phase. And 2019 onwards, we started performing robotic esophagectomy, and the first case was performed in 2019. Coming to the intraoperative details, The open transhiatal was performed in supine position in all patients, the transthoracic in supine and left lateral position. The minimally invasive, as I mentioned earlier, initial 20 cases were performed in lateral position. After that, most of the cases have been performed in the prone position, that is 63.6% patients. The route used to pull up the gastric conduit after resection, and by and large, all open cases we've used the posterior mediastinal route in the transhiatal group. But in the transthoracic group, in 2 patients, we had to use the retrosternal route to pull up the conduit. The reason being, one had a variant right subclavian artery, so that we could not use the posterior mediastinal route to pull up the conduit. And one patient had dense adhesions post-radiation, which prevented us from using the native route. Coming to the intraoperative challenges faced, post-neoadjuvant chemoradiation, in 23% of the patients, the dissection was difficult due to post-radiation adhesions and scarring. 14 patients had adjacent organ injuries in the neoadjuvant chemoradiotherapy group, accounting for 16%. 4 had thoracic duct injuries. 1 patient had a splenic laceration during preparation of the conduit. 4 patients had airway injuries. 4 patients had intraoperative bleeding. And 1 patient had a liver laceration of the left lobe during dissection. 3 patients had intraoperative tumoral perforation, which is considered as T4 disease later on if the tumor is perforated. That is accounting to 3.4%. And conversion was required in 14.7% of the patients. 1 patient in the open group, as I mentioned earlier, and 12 patients in the minimally invasive group. Reasons being predominantly difficult surgery post-radiation scarring was seen in the intraoperative field. 2 patients had poor ventilation, 2 patients had lung injury, and 1 patient had air leak intraoperatively. So coming to post-operative morbidity, major morbidity, Clavin Endo 3 or more. We use the Clavin Endo grading for post-operative morbidity scoring. Clavin Endo 3 grading is any patient who requires post-operative re-intervention in any form, either it be percutaneous, endoscopic, or post-operative re-exploration. Clavin Endo 4 is patients having any organ failures and requiring ICU care. And Clavin Endo 5 grading is patients who have post-operative mortality. So 40% patient had significant post-operative morbidity, out of which 32% patients had major pulmonary morbidity, 12.5% patients had major cardiac morbidity, 11.3% patients required post-operative re-explorations, 6.8% patients had organ failure and required ICU stay. And coming to mortality, by and large, the mortality rates have been constant to 9%. Either when we consider the learning curve from 2005 to 2015 or beyond from 2016 to 2019, the post-operative mortality rate has fairly remained the same. So coming to histopathological evaluation after the surgery, the mean number of lymph nodes retrieved are 7. Why are we looking at this figure? Because currently there is no consensus regarding the adequate number of lymph nodes to be retrieved after neoadjuvant chemoradiotherapy. And that is why this figure is important. We are still retrieving data, and currently there is no magic number which is available which defines adequate lymphadenectomy after neoadjuvant chemoradiotherapy. Node positive disease was seen in 19.3% patients, and the pathological complete response after neoadjuvant chemoradiotherapy was seen in 42% of the patients. That is 37 out of 88, which is quite encouraging. Just for completion, from 2019 to currently in 2023, we have performed 19 cases robotically, out of which 16 patients would undergo complete resection. 3 patients, we had to abandon the resection due to locally advanced growth. All patients were performed in prone position. Most of the patients were squamous cell carcinomas, and majority of the tumors were located in the lower 1/3. 15 out of 16 patients have received neoadjuvant therapy. Only the first patient was performed upfront. After that, most of the patients have received neoadjuvant therapy. Morbidity is seen in 2 out of 16 patients. Here it is 12.5%, but the denominator is still low, 16. No mortalities, and PAT-CR rates have been seen in 43.7%, which is consistent with the previous records of open and thoracoscopic surgery. Thank you. Now I call upon Dr. Shalin to lead the...
Thank you, Dr. Kush. So now the survival curve has been assessed differently. If you look at all comers, in other words, this survival curve looks at a 5-year survival, if you look at 60%, it looks at about 30% 5-year survival. But when you go a little beyond, let's say about 12 to 15 years, the survival is down to 20%. Now, this is a curve that has the full number of poor patients. In other words, those that were deemed inoperable, as well as those, So, and also they have the patients who came in initially and just received pre-operative radiotherapy. Now, two things happened in that data. In the pre-operative radiotherapy part, first of all, we have a lot of missing data there, and the follow-ups are off. And that is one reason for the explanation. And the second is that those who were not operated have been included here. So this is the data as it is. In other words, intention to treat. The surgeon has ascertained that the patient is good to go to the OT, but as you saw from the numbers, they discovered that this was that in about 10 or 12 or 15, they couldn't operate. So of those who've been operated, when you look at those numbers, they are substantially better. So the median survival, overall survival here is 23 months. And then, of course, those not receiving are 13 months. But the median survival, when you remove those patients, jumps straight away to 30 months. And for the others, obviously, that curve is unchanged. So one can view it both ways. And it is important that we show the data as it is. So now I will put in perspective the information on data with that of the best standard that the best standard that we have currently from a cooperative group in a Dutch cooperative group. As you know, in Netherlands, all the hospitals are of the government, and they include all patients, and it represents a very high standard of care. So this is the trial we are talking about, Van Harden et al. And there are many, of course, collaborators here. It's up to the entire country there. And when you look at their data, for those patients who received chemoradiotherapy followed by surgery, their median survivals are of the order of 40 months, whereas our median survival is of the order 50 months. That's 50 months here, but our median survivals are of the order of 30 months. And of course, there are differences. What are those differences? So let's look at the age. If you look at, let's look at the performance status. Now, 80% of patients were ECOG 0. These patients bike and cycle to your hospital and are, doing hard work and gymming around. That was just 5% in our population. And performance status is the single biggest, one of the single and most important factors that drive outcomes. What about the length of disease? The median was 4, it was 6 here, but there was the interquartile range was, the upper end was 6 centimeters. It was 7.5 in this case, none over than 8. They sifted out patients. Here, they were 14% over 8, and our tumors were literally 4 times the length of the median, maximum of 15 centimeters. Longer tumors, stands to reason that we will have different outcomes. And that really explains the curve. Also, their mortality was 4%, and our mortality here has been 9%. So these are the differences that we see. And so in summary, we are getting there. If you go back to the first slide that we talked about, when we looked at our data, we started off with this first surgical data. We looked at the survival 17 months, 1990 to 2005. Currently, using all comers, no absolutely purist approach, the survival is 26 months, 27 months. And if you exclude those that we operated, it's 30 months. So that's the kind of quantum jump that we've had. This is consecutive patient population. It's obviously not randomized. it's consecutive. And so these are the strengths of our analysis. I thank you all for your attention and happy to